Hello, and welcome to everyone for joining us for our discussion on the expert panel for bronchiectasis developments. I do not have any personal conflict of interest. I am Nauman Chaudhary. I'm professor of medicine at Virginia Commonwealth University. I'm director of the Adult CF Center. I'm going to pass my mic on to my next speaker.
I'm Dr. Alicia Mirza. I'm an assistant professor at Stanford University. There, I'm the associate director of the Cystic Fibrosis Center, as well as faculty at our Bronchiectasis Center of Excellence. Passing on to next faculty.
My name's Steve Lomach. I work at National Jewish Health. I'm an associate professor, and I head bronchiectasis and the PCD clinic here at National Jewish. Thank you for having me.
Hi, everybody. I am Chetna Painker. I'm a pulmonologist and director of pulmonary medicine at Bellin Health in Green Bay, Wisconsin. And I'm also an adjunct assistant professor with University of Wisconsin, Green Bay, with a special interest in bronchiectasis.
Thank you so much from our expert faculty. We'll start with the first question with Dr. Mirza. Can you please describe the key drug approvals expected in 2025 and how they may impact bronchiectasis care?
Absolutely. I'm actually very excited to be talking about this. But before I dive into specific emerging therapies, I do want to start by offering a framework for how we think about treatment strategies in bronchiectasis. As we know, bronchiectasis is a clinical syndrome with many possible etiologies, diverse endotypes, phenotypes, which we'll come back to that topic. But the first step in thinking about management is to identify the underlying etiology if possible to allow for targeted treatment, such as allergic bronchopulmonary aspergillosis or immunodeficiency. But that being said, it's important to recognize that up to 40% of cases remain idiopathic. So in parallel, we need to think about the core processes that drive disease progression to identify treatable traits. So this is where that concept of the vicious vortex becomes helpful, which describes bronchiectasis as a self-perpetuating cycle, persistent infection, inflammation, impaired mucociliary clearance that all leads to and perpetuates structural lung damage. So understanding these interrelated mechanisms allows us to identify therapeutic targets across the disease spectrum. And I want to use this framework to highlight some promising therapies. So one of the most talked about developments in bronchiectasis care right now is the oral therapy of the DPP1 inhibitors, which brensocatib is the one recently FDA approved and is specifically for non-CF bronchiectasis. So what makes brensocatib interesting is its mechanism, which directly targets chronic inflammation in a novel way. So it does this via inhibition of the dipeptidyl peptidase 1, or that DPP1 that I mentioned, which is responsible for activating neutrophil serine proteases like neutrophil elastase. And these enzymes are a big deal in bronchiectasis because they contribute to chronic neutrophil-driven inflammation and airway damage that is so prominent in the disease. So by targeting DPP1, brensocatib is directly addressing that harmful inflammatory cascade. So in the phase 3 ASPEN trial, which enrolled over 1,600 patients worldwide, it showed a statistically significant reduction in annualized pulmonary exacerbations when compared to placebo. And that's meaningful. Exacerbations of bronchiectasis are what can drive hospitalizations, of course, antibiotic use, and we suspect long-term lung function decline. And in the study, patients also had a longer time to first exacerbation, and we think preservation of lung function, a trend towards improved preservation of lung function. And as for safety, the data was generally reassuring. So I do think it's worth pointing out that the DPP1 inhibitors aren't a cure. It's not reversing airway damage. It's not for everyone. We still don't have biomarkers to exactly predict who will benefit most, though that's an area of active research. And like any anti-inflammatory drug, there's a balance to be struck between reducing harmful inflammation and also preserving the host defense. Still, the potential is exciting and is a shift to how we think about the management of bronchiectasis and options for addressing that underlying inflammatory process, and especially for patients who have had limited treatment options. We're pretty excited to have a new tool in the toolkit. I want to just briefly mention other areas of interest. Also, in the realm of chronic inflammation, label expansions of injectable asthma therapies could be in the future, those Th2 biologics for eosinophilic phenotypes, which we'll talk more about. In terms of mucociliary clearance, understanding the role of CFTR dysfunction and the possible role of CFTR modulators in incomplete CF phenotypes is being discussed. Again, nothing immediately expected, but still an area of interest. And then lastly, in the infectious space for non-tuberculous mycobacterium, we're looking at, we may see inhaled amikacin being utilized earlier in non-cavitary MAC as opposed to in refractory cases and waiting for the results of the ENCORE study, as well as inhaled clofazimine, which is being given fast track status for possible treatment for NTM. And then lastly, for Pseudomonas, which we all know and worry about in bronchiectasis as a contributor to mortality, anti-Pseudomonal antibodies, as well as phage therapy, are exciting treatments under investigation, although we don't expect any approvals like within the year.
Thank you so much, Dr. Mirza. That was very knowledgeable, very thorough, and really great to hear about the first approved therapy by FDA, which is brensocatib, as you mentioned. Next question is for Dr. Lomach. Can you please describe the heterogeneity of bronchiectasis and why is it relevant in clinical practice?
Sure. I think I'd start off with just letting the audience know that 40% of the time patients don't get the comprehensive sort of guideline recommended evaluation. And there's over 30 causes to bronchiectasis. So it's so important to sort of be diligent because a lot of patients go unrecognized and then the exact etiology never gets determined and it does affect treatment. Case in point, I had an 80-year-old that had NTM, non-tuberculous mycobacterium, and had bronchiectasis for the prior decade. And my colleagues here at the ID clinic had referred her for further evaluation and management of the bronchiectasis. And we found out that she had cystic fibrosis. And so that's the oldest patient I've diagnosed with a new diagnosis of CF. I just remember her looking at me and going, "So when did I get this?" And I'm like, "Actually, you've had it your whole life. It just went unrecognized." And so just thinking of, the different thorough evaluation, if I think of what are the big categories, I think of genetic, autoimmune, immune dysfunction or low immune system, infectious, and aspiration causes. And so a lot of the things that we order, such as antibody panels or sweat chloride, we look at of course, the immunoglobulins for being immune deficient, but it's being very detailed and just going along and not treating the patient like you think you know what they have versus just being open that they could have anything. I know one of my partners here at National Jewish, he was 72 and he had 2 pneumonias and he came to me just because he goes, "Well, why am I getting pneumonia at age 72? And we did a CT and we found bronchiectasis. And I just went, and it was very mild, but went down the algorithm of what to work up. And alpha-1 antitrypsin is one of those things that you should work up. And he actually had alpha-1 antitrypsin, a new diagnosis, and somebody who works right here with me, The other thing to keep in mind when you're doing an evaluation of the different causes, which we just said were numerous, is knowing some of the error rates in your test. I had a patient that was referred and he had immotile sperm, and somebody had thought of primary ciliary dyskinesia and did the biopsy, but it was negative and they left it there. But, biopsies are 30% false negative. So you miss it 30% of the time on biopsy. And when we did the nasal nitric oxide is not readily available to everybody. But we did the nasal nitric oxide and it was very low. And then we did the mutation analysis and saw he had 2 mutations. So he actually did have primary ciliary dyskinesia. So I think the key is just keep an open mind, be very diligent, and don't, be so focused that you miss some of these atypical presentations, and know the error rates of your test.
Thank you so much, Dr. Lomach, for that very informative discussion to really have a etiological significance of heterogeneity and working up very thoroughly and keeping your mind open, and then properly addressing all the therapeutic implications of this heterogeneity of presentations. My next question is for Dr. Penkar. Non-tuberculous mycobacterium bronchiectasis is very common in bronchiectasis patients. Describe if it has a role in cause or as a prognostic marker in this disease.
So this is thank you for the question, Dr. Chaudhary. This is a pretty interesting question because NDM can serve as both a causative agent, as well as a prognostic marker in bronchiectasis. As we know, non-tuberculous mycobacteria, particularly MAC or Mycobacterium avium complex, is frequently isolated in patients with bronchiectasis, but the role of it is more nuanced. In most cases, NTM is a secondary infection where, the NTM will take advantage of the already damaged airways, the impaired mucociliary clearance, the mucostasis, and the inflammation to kind of, creates a perfect environment for NTM and it colonizes and persists. But yes, there is definitely that subset of nodular and non-cystic forms of bronchiectasis where there is definitely a growing evidence that NTM infection may actually drive the progression itself and worsen the inflammation and cause more structural damage. What we for sure know is NTM's role in prognostication with bronchiectasis, where it definitely is a negative prognostic marker. It's associated with increased exacerbation, accelerated lung function decline, greater radiologic severity, as well as, associate needs more prolonged multi-drug regimens for a longer period of time. In one of the US registries, we definitely found like 38% of the bronchiectasis patients who, had a positive NTM positivity, which, makes it very relevant in our patient population. And knowing, and the chicken and egg is not a problem, but knowing whether, how it can negatively impact our patients, I feel definitely plays a role. Thank you.
I think identifying NTM is important, of course, because there's targeted therapy that may slow or prevent progression of disease. But I do want to point out that there is some nuance here. I think the field is generally moving towards earlier treatment, but even with that, not all patients with NTM pulmonary disease require therapy. We know it's an extended treatment, antibiotics are prolonged and may be difficult to tolerate. There could be other complications as well. So thinking about patient and environmental factors that lead to disease progression, I think is important. And we're still trying to understand the various genetic factors that are almost certainly at play. Thinking about things like, AFB smear positivity or the type of radiographic disease becomes quite relevant. Just one thing to mention, I think, is the tool of the BASES score, which I think is helpful and want people to be aware of, which can be used to predict mortality in patients with NTM pulmonary disease. It's one of those acronyms, which is nice because it kind of tells you what's in it with BASES. So it's looking at the characteristics of BMI, age, presence of a cavity, see elevated ESR, and sex. So a higher BASES score indicates a worse prognosis.
Thank you very much to both Dr. Penkar and Dr. Mirza for highlighting this important concept about cause and prognosis in NTM. My next question is for Dr. Penkar again. What is known about clinical endpoints in bronchiectasis?
So as we know, there's a lot of variability in the clinical endpoints, especially when we are, trying to do our clinic, compare our clinical trials or try to kind of assess the efficacy of treatment because of the variability in the definitions of these. But the common endpoints that we usually use is like the exacerbation rate, where there's definitely a difference in definitions depending on which study you read. The quality of life tools such as SGRQ or the bronchiectasis health questionnaire, the lung function like FEV1, which may or may not be responsive to, the clinical clinically to the treatment parameters. Radiologic progression for sure, microbial clearance, especially with respect to NTM or Pseudomonas, and then inflammatory markers and exercise, capacity. So the CRP, the 6-minute walk test. Now there are more emerging which endpoints which we are looking into more granularity of patients' clinical presentations, such as time to first exacerbation, which will show us how effective this is in, delaying the symptoms of flare-ups, hospitalization rate, rate of use of rescue antibiotics in patients, or patient-reported outcomes, because what we don't see on our testing with respect to the FEV1, patient may definitely have improved fatigue, cough severity, so on and so forth. And then with the more wearable technology that we have, we can start looking into outcomes such as tracking the mobility of the patient, tracking the lifestyle impact, so on and so forth. Definitely the prognostication is not complete without including more of the bases or the FACE or the BSI, which gives us a more holistic outcome for patients with bronchiectasis.
Thank you so much. That was very detailed and a lot of wealthy information there for me to learn from to see how to design the futuristic studies of bronchiectasis going forward. I know that has been a limitation in the past from some of the inhaled antibiotic studies that were done because of some of the lack of these endpoints. So thank you for all of that. And my last question is for Dr. Lomesh, coming back to him again. What are the key publication results in the first quarter of 2025 in bronchiectasis, and if you know of any other publications that may be upcoming? Thank you.
Yeah, I think we've already touched on probably the biggest thing that's come out in a long time, but let alone just last month, is the Aspen study in the New England Journal, and how that showed brensocatib decreased exacerbation rate. But in the higher dosing, so it was for the adults, it was a 1:1:1, which is a 25 milligram dose, a 10 milligram dose, in a placebo. And at the 25 milligram dose, not only did it decrease exacerbations over the year, it actually did show that there was a signal for decreased FEV1 decline. So that was sort of an interesting add-on point too. But beyond that big sort of publication, there were two that I sort of thought were interesting. There was one in the thorax in March, and it was out of the Embark European Bronchiectasis Registry. And they were looking at more of that eosinophilic phenotype. And so if patients showed an eosinophil count greater than 400, and they were treated with inhaled corticosteroids, they actually did show a decreased exacerbation rate. And I think that's sort of telling, and in telling the importance of phenotyping our patients and not just saying inhaled steroids, which in bronchiectasis in the guidelines, we try to avoid because we're always worried it could increase the risk of infection in an airway disease already at risk for infection. And so we do try to avoid inhaled steroids, but perhaps we need to be better at pursuing the different type of phenotypes. Specifically in this paper, it's highlighting eosinophilia, but we know that patients with ABPA do better when they're treated with inhaled steroids. And also, as mentioned by one of our speakers, the biologic agents are showing promise in certain phenotypes, specifically the ABPA patient and Dupixent or dupilumab. So I think it's important to not just treat every bronchiectasis patient the same, which ties into my earlier sort of statement about, well, what are the different causes? With over 30 causes, we need to get to what is the specific phenotype and then eventually endotype of this specific patient in front of me, so that I can use targeted therapy rather than just sort of saying everybody needs to be treated the same. And as we keep coming out with these different agents, we know already, so for common variable immunodeficiency, there's antibody therapy. For alpha-1 antitrypsin disease, there's giving alpha-1 protein back. for ABPA, steroids and biologics. If you identify somebody with cystic fibrosis, these new modulator therapy. So it's getting more and more important to actually do the due diligence to figure out this type of patient, of what is driving the disease, and target the therapy around that.
Thank you so much, Dr. Lomash, for the very interesting discussion, and to all my panels to have the very specific, tailored approach and precision therapy as the norm is these days for bronchiectasis patients. So I really appreciate for you all to joining and spending the time and educating our audience here. I hope our audience liked the brief panel. Due to the nature of the panel, we could not discuss everything, and I hope we can discuss these things in the future. If you like this, please show us a like, thumbs up with this, and so we can continue to do this. Thanks to Chest for organizing this and allowing us to record it. And we look forward to having you in the future series of this section. Thank you so much again, everybody.